Hi guys, and welcome to Psych for Everyone. I'm Dr. Naza. Today we're going to talk about major depression disorder, how to make a diagnosis, and how to treat. And also we're going to talk about treatment-resistant depression, which is a big nightmare for patients and providers in the same time. Before we start talking about diagnosis and treatment, we need to dive into the historical aspect of depression. So, depression is one of the oldest psychiatric illnesses described in human history. Its origins can be traced to around 400, 500 BCE, when Hippocrates conceptualized the condition as melancholia within the framework of humoral theory. According to that model, persistent sadness, fear, withdrawal, insomnia, loss of appetite, and hopelessness were attributed to an excess of what he called black bile. And at that time, he actually gave a treatment recommendation, which really reflected a holistic approach and included diet, exercise, bath, music, philosophy, and even social engagement. Then during the medieval period, depression was reframed as acedia, which is a state of spiritual sloth or despair. This condition was often interpreted as a moral failure or the result of demonic influence rather than a medical illness. And at that time, care was largely provided in monasteries, with treatment actually centered on prayer, confession, and penance, and minimal medical intervention. And then the Renaissance period between 1400 and 1800 marked a renewed interest in the mind-body connection and more nuanced conceptualizations of depression. A landmark contribution came from a guy named Robert Burton, whose work, The Anatomy of Melancholy in 1621, really offered the first systematic and comprehensive description of depressive symptoms. Burton emphasized the interplay of biological, psychological, and social factors and framed melancholia as a disorder influenced by stress, loss, and temperament. Big change in the history of depression. Then the 19th century came and really ushered in the birth of modern psychiatry. So Emil Kraepelin distinguished manic depressive illness from schizophrenia and actually classified depression based on course, severity, and recurrence. And in the early 20th century, of course, Sigmund Freud came in Mourning and Melancholia in 1917. He conceptualized depression as internalized anger toward a lost object rooted in unconscious conflict and early childhood loss. Very interesting description of depression. This psychoanalytic model led to long-term psychotherapy becoming the dominant treatment approach for depression. So really in the 19th century, actually even earlier in the 18th century, things went out from monasteries to physicians and psychologists. A major paradigm shift occurred in the 1950s with the emergence of the monoamine theory of depression. And at that time, observations that the tuberculosis medication iproniazid improved mood led to the discovery that inhibition of monoamine oxidase increased level of serotonin, norepinephrine, and dopamine. This finding established the first modern biological model of depression and laid to the foundation for contemporary psychopharmacology. So really at that time in TB sanatorium, patients who were treated with iproniazid, they had brighter affect, they felt better. So they studied this medicine and they found that it blocks the monoamine oxidase enzyme, increasing serotonin, norepinephrine, and dopamine. And this is when they thought, okay, so depression is low serotonin, dopamine, and norepinephrine. And then the Diagnostic and Statistical Manual of Mental Disorder, or DMS, DSM, came to light. And the major depressive disorder as a formal diagnosis is a relatively modern construct that emerged alongside the development of standardized psychiatric classification systems, particularly the Diagnostic and Statistical Manual of Mental Disorders, or the DSM. Prior to the DSM era, depressive states were broadly conceptualized as melancholia or as part of manic depressive illness without clear diagnostic boundaries. DSM-1 reflected psychodynamic framework and classified depression under depressive reaction, emphasizing responses to environmental stressors and internal conflicts rather than discrete disease entities. This conceptualization continued in DSM-2, which used the term depressive neurosis and maintained strong psychoanalytic influence with limited operational criteria and poor diagnostic reliability. A major paradigm shift occurred with DSM-3, which introduced major depressive disorder as distinct diagnosis. This edition separated unipolar depression from bipolar disorder, abandoned ideologic assumptions, and implemented explicit symptom-based criteria, duration, thresholds, and exclusion rules. This marked psychiatry's transition to descriptive and more biologically compatible model. Subsequent editions like DSM-3R and DSM-4 and DSM-4TR refined symptom definitions, clarified subtypes, and formalized specifiers such as melancholic depression, atypical, psychotic, postpartum, seasonal features, while emphasizing functional impairment and recurrence. DSM-5 preserved the core diagnostic structure of major depression disorder, but removed the bereavement exclusion, acknowledging that major depression can be triggered by loss while still representing a pathological process. It also expanded specifiers to capture dimensional severity in course. Now, the most recent revision, which is DSM-5TR, made minimal diagnostic changes that updated language, clarified criteria, and aligned terminology with contemporary neuroscience and clinical practice. So overall, the DSM evolution of major depression disorder reflects a shift from moral and psychodynamic interpretations toward a standardized, symptom-based, biopsychosocial framework, improving diagnostic reliability while continuing to grapple with the heterogeneity of depressive illness. In contemporary psychiatry, major depression disorder is best understood through a neuroplasticity-based circuit-level model, with brain-derived neurotrophic factor, or BDNF, playing a central role. Beyond the traditional monoamine hypotheses, modern theory emphasizes that chronic stress and depression are associated with impaired neuroplasticity and disrupted connectivity within mood-regulating circuitry involving the prefrontal cortex, hippocampus, and amygdala. So chronic stress and dysregulation of the hypothalamic pituitary adrenal axis, or the HPA axis, result in elevated cortisol levels, which suppresses brain-derived neurotrophic factor expression. This leads to reduced synaptic density, dendritic atrophy, and impaired neuronal resilience. These changes help explain core depressive symptoms, including anhedonia, cognitive impairment, emotional rigidity, and poor stress tolerance. Effective antidepressant treatments, including pharmacotherapy, psychotherapy, exercise, electroconvulsive therapy, and rapid-acting agents such as ketamine, and of course, repetitive TMS or deep TMS, converge on restoring neuroplasticity by increasing brain-derived neurotrophic factor signaling and promoting synaptogenesis and neurogenesis, actually, particularly in the prefrontal cortex and hippocampus. From this perspective, brain-derived neurotrophic factor serves as critical downstream mediator linking stress, neurotransmitter system, inflammation, and genetic vulnerability rather than a singular causal factor. So modern psychiatry conceptualized major depression disorder as a stress-related network disorder characterized by reversible impairments in neuroplasticity. So let's make it easier and more structured to understand. So the neurobiology of major depression disorder, the etiology is depression is a polygenic disorder with significant gene-environment interaction. On the epigenetic side, DNA methylation and histone modification link early adversity and chronic stress to altered mood-related gene expression. Then the chronic stress comes, and every time people get a stressful event, they get a cortisol surge. The chronic stress is going to impair the negative feedback, increasing cortisol, and that's going to cause hippocampal damage. And this somehow, the chronic stress will increase C-reactive protein, interleukin-6, tumor necrosis factor alpha, and that's going to cause like a cytokine-mediated neurotransmitter disruption and reduce neuroplasticity. On the neurotransmission level, this is going to lead to decrease in serotonin, norepinephrine, and dopamine. We knew that since the monoamine theory, if you remember. And also, it will lead to compensatory serotonin receptor upregulation. We would also have imbalance between the excitatory and inhibitory neurotransmitter. So for example, glutamate is an excitatory neurotransmitter, will be increased in major depression, and GABA will be decreased, which is an inhibitory neurotransmitter. So pretty much here, the glutamate, which is like the Mad King, will send the dragons to actually kill all the people, just like in Game of Thrones. The neurotrophic support, then, like brain-derived neurotrophic factor, will decrease or reduce. That is going to impair synaptic plasticity and neurogenesis. And literally, the brain will go into a vicious circle or cycle. So really, all what it takes, genes and epigenetic vulnerability, like someone with family history, plus they have lots of epigenetic vulnerability, then they get stress. And this chronic stress will cause HPA axis dysfunction and chronic cortisol increase. That's going to lead to increase in the inflammation in the brain by increasing C-reactive protein, interleukin-6, TNF-alpha, and cytokine-mediated neurotransmitter disruption, decrease in serotonin, dopamine, norepinephrine, increase in glutamate, decrease in GABA, upregulation of some of the bad serotonin receptors, and decrease in brain-derived neurotrophic factor, which is the compensatory mechanism. So BDNF, every time you have a neuronal damage or you have an illness in the brain, the brain-derived neurotrophic factor goes up, so will cause neurogenesis and synaptogenesis. That means building new neurons and new connection to fill the gap that happened from the injury. Well, the depressed brain is unable to do that. And that's really the modern theory about how people get major depression. Another important factor in major depression and treatment of major depression is what we call the serotonin transporter gene, or the 5-HTT-LPR gene. So for decades, we used tricyclic antidepressant, SSRIs, SNRI to treat major depression disorder. So they work, we call them reuptake pump inhibitors. So they block the reuptake pump. Now we call the reuptake pump the serotonin transporter. So the gene responsible for the serotonin transporter is SLC6A4. And sometimes we get polymorphism, which is 5-HTT-LPR, short and long alleles. So normal patients have LL. So one of the long allele and the other L allele, two long alleles. That means we have increased transporter expression and relative stress resilience. And even if these patients get depressed, you give them an SSRI, and this medicine should work because they have enough of the serotonin transporters or the reuptake pumps present to work on. Now, the problem, if we have polymorphism and we have one of the short allele instead of the long allele. Now, either LS or even SS, which is even worse here. So short allele plus early life adversity or chronic stress increases depression risk, and also associated with increased amygdala reactivity and HPA axis activation. But, of course, this allele alone is not diagnostic for depression or anxiety, but we know that the presence of this allele increases vulnerability to depression in the presence of stress via altered serotonin signaling and heightened stress reactivity. And actually, these patients who have one of the S allele or the short allele or both, they have reduced response to the classical antidepressants from the SSRI class, SNRI, and tricyclic antidepressants. Back in the days when people failed all the above, we used to give them monoamine oxidase inhibitors because it works in a different way. Of course, now in 2025, we have plenty of other options. The other gene that is very involved in depression and treatment-resistant depression is the MTHFR gene, which is the one responsible for the conversion of folic acid to L-methylfolate. So, or to tetrahydrofolate. So the gene is called MTHFR, and the function of this gene is the conversion of folate to L-methylfolate for monoamine synthesis. And we have like couple polymorphism, the C677T and the A1298C. And really, when that happens, when we have gene mutation, we may have reduced enzyme activity, and that means that's going to decrease L-methylfolate and SAMe. It will cause impaired in monoamine synthesis, elevation in homocysteine with neurotoxic and inflammatory effect. And that will actually increase risk for major depression disorder and treatment resistant depression. And actually, most of the antidepressant may not work very well because, with antidepressants, we actually block the reuptake pump or the serotonin transporter, increasing serotonin in the synaptic cleft. But these folks don't have enough serotonin to start with because they have polymorphism in the MTHFR gene. So that means, literally you can think about it as two wheels, and they are connected. The first wheel will convert folic acid to tetrahydrofolate. That's the MTHFR gene. When this happens, this will turn the other wheel, which is the conversion of tryptophan, which is an amino acid, to 5-hydroxytryptamine, which is serotonin. So the conversion of folic acid to tetrahydrofolate or L-methylfolate is very important for the conversion of tryptophan to 5-hydroxytryptamine or serotonin. So our brain does not form enough serotonin if we have polymorphism in this gene, pretty much. So really the treatment implication, L-methylfolate supplementation may augment antidepressant response, and now also just high dose or higher dose folic acid may be beneficial and may be enough. We have lots of debate in this area. The other thing about major depression disorder, the moment the brain becomes depressed, you can actually see it on functional imaging. So the areas or the brain regions involved in major depression disorders are prefrontal cortex, anterior cingulate cortex, amygdala, hippocampus, basal ganglia, hypothalamus, and thalamus. So here you may tell me, oh gosh, that's pretty much the whole brain. Yes, it is the whole brain, except probably the occipital lobe and the brainstem. And who knows, in the future, we may have some data that we have something there that we don't know about. So again, it's prefrontal cortex, anterior cingulate cortex, amygdala, hippocampus, basal ganglia, hypothalamus, and thalamus. And of course, I would throw here the nucleus accumbens, which is the pleasure center as well. So the prefrontal cortex, the main one involved in depression, is what we call the dorsolateral prefrontal cortex. We can shorten it as DLPFC. This one, we have decreased activity, and that is going to cause impaired and executive function and poor connection. This is what we target when we do transmagnetic stimulation. We actually target the DLPFC, the dorsolateral prefrontal cortex. The ventromedial or orbitofrontal prefrontal cortex also involves, so dysfunction there will give negative bias, impaired emotion, emotional regulation, stuff like that. The other area is anterior cingulate cortex, or ACC. So the subgenual ACC, or what we call the BA25, will have actually increase in activity. So the DLPFC, the ventromedial, we have decrease in activity. This one, the anterior cingulate, actually we see increase in activity, and this is responsible for sadness and rumination. So actually, this is a key target for deep brain stimulation in refractory depression. Amygdala, which is your fear response, we have increased reactivity, causing exaggerated negative emotional processing and hyper-responsiveness to stress and negative stimuli. Hippocampus is the other area, and we see decrease in volume. That's actually stress related, and that's going to cause impaired neurogenesis and memory. Actually, one of the richest area of the brain in stem cells, and we have lots of neurogenesis that happen there, is the hippocampus, and we have impaired neurogenesis and memory, and it could cause vulnerable to chronic cortisol exposure, and that is a big thing that happen in depression. Basal ganglia, and actually there we will have decrease in dopaminergic activity, reduced motivation, and also the nucleus accumbens, we have a decrease in dopaminergic activity that could cause anhedonia, or loss of pleasure in pleasurable activities. Hypothalamus, HPA axis dysregulation will cause increase in CRH and increase in cortisol, links stress to endocrine and immune changes. Thalamus and thalamic dysfunction, abnormal sensory emotional integration, that will contribute to altered perception and mood regulation. And now let's talk about the depressive disorders. So DSM-5-TR classifies depressive disorders as persistent mood disturbances with cognitive, behavioral, and somatic symptoms causing clinically significant distress or impairment. An accurate diagnosis requires exclusion of bipolar disorders and identification of medical and substance-related causes. It's very important to know. In psychiatry, I do not have a test that will tell me this patient has major depression disorder. And the symptoms of major depression disorder could happen from daily life stressors. So I really need to know, do my patients qualify for major depression disorder, which exactly what I say, genetic, epigenetic, inflammatory illness, right? Or not. So really, that's why we need to be very strict and follow DSM-5-TR criteria very closely. So the first illness in the depressive disorder is major depressive disorder. Patients should have significant impairment for more than 2 weeks, 2 weeks and more. And they should have at least 5 symptoms. One of these symptoms should be depressed mood or anhedonia. And here, depressed mood stated by the patient or someone who knows the patient very well. If the patient tell you I'm fine, but their family members say, well, we've known them for 75 years and we know they look depressed. So the 5 symptoms that you need are from the following symptoms. So depressed mood most of the day, nearly every day, loss of interest or pleasure, or what we call anhedonia, significant weight loss or gain or appetite changes, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feeling of worthlessness or excessive guilt, poor concentration or indecisiveness, recurrent thoughts of death or suicidal ideations. And of course, the patient should not have any history of mania or hypomania. Now, persistent depressive disorder, this one, the patient should have more than 2 symptoms for at least 2 years in adults and 1 year in children and adolescents. It's very important to know that. So more than 2 symptoms for at least 2 years in adults and at least 1 year in children and adolescents. Now, back in the days, we used to call something like double depression, which is the patients with persistent depressive disorder, and they get like a major depressive episode every once in a while. So we used to call it double depression. It's not in DSM-5-TR. The other one is disruptive mood dysregulation disorder. The disturbance should be more than 12 months, and the patient should have severe temper outburst and persistent irritability. Onset should be before age 10, and most likely the diagnosis will be between 6 to 18, but if you go back in the history, it should have started before age 10. Then we have premenstrual dysphoric disorder, which is mainly the luteal phase symptoms for more than 12 months, and the patient will have full remission after menses. Substance or medication-induced depressive disorder, you should establish a temporal relationship to substance exposure. 1 month of sobriety is required to diagnose major depression disorder. So, for example, if you have someone who's depressed and they've done any kind of psychoactive substances within a month of the symptoms onset, that means their diagnosis is substance-induced depressive disorder. If they tell you, I've been depressed for so long and I've done drugs only for the past couple weeks, here their diagnosis is major depression disorder. So really you need to see the temporal relationship to substance exposure and make sure you do not diagnose major depression disorder unless the patient has been sober from all substances for at least 4 weeks. Depressive disorder due to another medical condition, you should establish direct physiological consequence of illnesses in causing depression. So, for example, someone with untreated hypothyroidism, and you cannot find any other reason for depression, like no family history, no previous depression, and now you diagnose them with hypothyroidism and they are depressed. Or someone with pancreatic cancer, for example. The other one that is biggie in this area is actually diabetes. Also, we have growing B12 deficiencies in our modern world, not because we have dietary restrictions like vegan diet. No, it's not only that, but the major thing now that we see is medication induced. Like some diabetes medicine like metformin could cause B12 deficiency, or other kind of medications like anything that reduce stomach acid could cause B12 deficiency. DSM-5-TR includes specifiers to further characterize the clinical presentation, course, and associated features of depressive disorders. Specifiers refine diagnosis, guide treatment selection, and inform prognosis by capturing symptom pattern, severity, and temporal context beyond the core diagnostic criteria. So the first one, and in my opinion, very important, the most important specifier for depressive disorders is severity and course specifiers. So depressive episodes may be specified as mild, moderate, or severe based on symptom numbers, intensity, and functional impairment. In severe depression, we should address psychotic features. So, if we're diagnosed at mild or moderate major depressive disorder, we do not have to say with or without psychotic features. Anyway, they should not be with psychotic features, because if there is psychotic features, the diagnosis will automatically becomes major depressive disorder severe. In severe depression, again, we have to specify whether we have psychotic features or not. Episodes can also be described as in partial remission or in full remission, reflecting residual symptoms burden and recovery status. These specifiers are critical for treatment planning and monitoring of response. The actually newer features in DSM-5 and DSM-5-TR is anxious distress. So this specifier is applied when prominent anxiety symptoms accompany a depressive episode, including restlessness, excessive worry, fear of losing control, or anticipation of catastrophe. The presence of anxious distress is associated with greater symptom severity, increased suicide risk, poorer treatment response, and actually more chronic course. So it's very important for me to specify, do I have anxious distress features? And here, lots of folks may ask me, so what's the difference between anxious distress feature and the presence of comorbid generalized anxiety disorder? Well, again, the temporality of symptoms. Did we have generalized anxiety disorder symptoms for the past 6 months, even before the depression started, or all the anxious or anxiety symptoms came after the depression? That will give you your diagnosis. With melancholic features. So melancholic depression is characterized by profound anhedonia and lack of mood reactivity. So pretty much the patient would not enjoy anything and they do not have mood reactivity. And they tend to have problem in the morning. So they have early morning awakening. Depression is worse in the morning, better in the afternoon. They tend to have psychomotor retardation or agitation, excessive guilt, significant weight loss, and again, depression is usually better at night and worse in the morning. Atypical features. I think this is the most confusing features ever because it's called atypical, but it's actually very common. So atypical depression defined by mood reactivity. Very important. Reactivity of affect. That means patients react positively to positive things. That means if I'm depressed, suddenly someone brought me a gift, I'm going to feel happy. And people will be like, what the heck? They should not be depressed because they look happy. Now, at least. So there is lots of other features. The patient should have at least 2 other symptoms beside mood reactivity. Hypersomnia, they sleep more than usual. They eat more than usual. They have increased appetite or weight gain. Leaden paralysis. When people tell you, oh my goodness, I feel that my arms and legs are so heavy, I can barely move them. That's leaden paralysis, which is one of the symptoms of atypical depression. Rejection sensitivity is a biggie. So really, despite the term atypical, this presentation is very common and is often associated with earlier onset, higher comorbidity with anxiety disorders, and favorable response to certain antidepressant classes. Like typically, monoamine oxidase inhibitors are very good for this kind of depression. But literally, if I have anything that works on the dopamine, should work or may work for this kind of features. Psychotic features, again, this is severe depression. The specifier applies when delusions or hallucinations occur during a depressive episode. So psychotic features may be mood congruent, like guilt, worthlessness, nihilistic or nihilism, or mood incongruent, which is very different from the content of the mood. Psychotic depression is associated with increased severity, functional impairment, and suicide risk, of course, and typically requires combination of antidepressants, antipsychotic treatment, or even electroconvulsive therapy. There's lots of psychiatrists that would tell you if you see severe major depression disorder with psychotic features with very limited functionality, think about ECT even to start with. Catatonic features. Here you may tell me, oh, why do I have catatonic features in major depression? Well, the most common illness that would cause catatonia is not schizophrenia, is actually affective disorder, depression, and bipolar illness. So catatonia may occur in severe depression. And here we have like psychomotor disturbances, just like stupor, mutism, negativism, posturing, echolalia, which is pretty much repeating whatever the other is saying, or echopraxia, which is doing the same things that the other people are doing. Recognition is very important because this illness could become what we call malignant catatonia very fast, and patients could have very bad outcomes. So every time you're suspecting catatonia, try to go with the benzodiazepine challenge and always think ECT, electroconvulsive therapy. Postpartum onset is a very important specifier, and this is used when depressive symptoms begin during pregnancy or within 4 weeks following delivery. So really, this is 4 weeks before delivery or 4 weeks after delivery. And this is a very important topic now because we have lots of new therapeutic and treatment for peripartum depression that we should offer to the pregnant woman or the postpartum woman. This one is associated with hormonal fluctuations, psychosocial stressors, and increased risk for adverse maternal and infant outcomes. So really underscoring the importance of early detection and treatment. Please screen for peripartum depression if you're seeing women in childbearing age who are pregnant. Seasonal pattern is another one. So really depressive symptoms that occur at a specific time of the year, most commonly fall or winter. But yeah, do I have patient that tells me we feel worse summertime? Yes, absolutely. So this pattern is associated with circadian rhythm dysregulation, reduced light exposure, and may respond well to light therapy. But again, some people may tell you I'm worse summertime. So really, to summarize it, for major depression disorder, you need more than 2 weeks of symptoms. You need at least 5 symptoms, and one of these symptoms should be depressed mood or anhedonia. Persistent depressive disorder, what we used to call dysthymia or dysthymic disorder, more than 2 years in adults and more than 1 year in children and adolescent, and the patient should have more than 2 symptoms. Disruptive mood dysregulation disorder, more than 12 months, no symptom-free period for more than 3 months. Onset is usually before age 10. Premenstrual dysphoric disorder, present in most cycles for more than 12 months, and actually symptoms should resolve after they see the menses. Substance or medication-induced depressive disorder, this one is secondary to substance use. And again, you cannot make a diagnosis of major depression disorder unless the patient is sober for at least 4 weeks. Depressive disorder secondary to another medical condition. This is concurrent with medical illness. And we have unspecified depressive disorder. This is when the depressive symptoms do not meet criteria for any of the above. Now I'm going to talk about the very important thing in clinical psychiatry: the difference between adjustment disorder and major depression disorder. So lots of time residents and medical students tell me, well, this is adjustment disorder. Then I go over the symptoms and we end up deciding this is not adjustment, this is major depression. So, any life stressor could cause adjustment disorder, but also could initiate a major depressive episode. See what I mean? So adjustment disorder is frequently included in the differential diagnosis of depressive disorders. represent a time-limited, stress-related, subthreshold condition in which emotional or behavioral symptoms develop in response to an identifiable psychological stressor. So by definition, the clinical presentation does not meet full criteria for another psychiatric disorder. That means I have a stressor. The stressor should be within 3 months of the onset of symptoms. If the symptoms meet criteria for major depression disorder, this is major depressive disorder. If they have more than 5 symptoms, one of them is depressed mood or anhedonia for more than 2 weeks, I cannot make a diagnosis of adjustment disorder. My diagnosis is major depressive disorder. So really, for adjustment disorder, we should have an identifiable psychological stressor within 3 months of symptom onset. For depression, may occur with or without a stressor, and there's no required temporal link to stressor. Duration, usually adjustment disorder symptom resolve within 6 months. Major depression episode lasts more than 2 weeks. Hopefully will go away at some point, or hopefully the patient will be treated to get this. Severity of adjustment disorder, usually subthreshold for major depression. But really, for major depression, they should meet full criteria for major depression. Usually for adjustment disorder, we have depressed mood, tearfulness, hopelessness, fewer neurovegetative symptoms. For major depressive, we have more than 5 symptoms. Very severe, could be suicidal ideations. And usually the stress is out of proportion to stressor, but usually milder, versus in major depression, we have marked functional impairment. Suicidality is typically absent or passive in adjustment disorder, but the patient with major depressive disorder may have active suicidal ideation or behavior. It's not a must, because lots of patients with major depression disorder, luckily, they do not have suicidal thoughts or suicide attempt. And usually adjustment disorder course improves with stress resolution or adaptation, but the major depression disorder may persist despite resolution of stressor. Do not treat adjustment disorder with psychotropics. It's not going to work. The patient's going to tell you, oh, I failed 5 medicine because every time I fight with my wife and my wife leaves me or my partner leaves me, I get depressed. That's like adjusting every time this happens. And they try me on a medicine and it doesn't work. So psychotherapy, stress management, reassurance, treatment focus for adjustment disorder. Major depressive disorder, antidepressant, psychotherapy. This really emphasizes that you need to make the right diagnosis to have the right treatment. Again, a big thing in psychiatry, patients don't respond to medication because we have the wrong diagnosis. Now we're going to talk about treatment of major depressive disorder. And this is actually a suggested treatment plan or algorithm based on the most recent evidence-based medicine and lots of my experience as well. So the first thing you need to do is to confirm diagnosis and assess severity. Very important. You need to know that you're dealing with major depression disorder and not anything else. So you have to rule out bipolar disorder, substances, medical causes, personality, and also personality disorders, and also that this is just normal depressive symptoms from life stressors. Because really, if it's bipolar disorder, if you have substance use, using antidepressants is not going to work. If you have someone depressed from medical problems, giving antidepressant is not going to work. If you have someone with personality disorder trying to give psychotropics to treat something that doesn't exist, which is the major depressive disorder, it is not going to work. Of course, you need to know that patient with personality disorders, they could have comorbid major depression disorder, and here giving antidepressant to these patients may be beneficial. The second thing, you need to assess severity, suicidality, psychosis, and catatonic features. Very important to do this step. So really the first step, in my opinion, is the most important step in treating major depression disorder, confirming diagnosis and assessing severity. The second one, which is the initial treatment. So now we know we have major depression disorder, and we know it's either mild, moderate, or severe. So mild major depression disorder, it is better to talk about psychotherapy alone to start with. So cognitive behavioral therapy, interpersonal therapy, behavioral activation, even some supportive therapy is a good starting treatment for patient with mild major depressive disorder. We need to monitor for 4 to 6 weeks and then reassess. Do I have any change in severity? Do I have symptom response? If no response, we go to the second step, which is where we start if someone has moderate major depression disorder. So in moderate major depressive disorder, it is very important to do both a medication treatment or psychotherapy, or both. Actually, doing both is much more preferred. Antidepressants, any selective serotonin reuptake inhibitor is a good start. And here, SSRIs are not medicine with exactly the same profile. They are different. So, for example, we have like two activating SSRIs, fluoxetine and sertraline. So if your patient is more like have psychomotor retardation, probably starting one of these two agents is preferred. A neutral SSRI is escitalopram. Sedating SSRIs, we're talking about citalopram, paroxetine, and fluvoxamine. The other thing about SSRIs is medical comorbidities. If someone has a bunch of medical comorbidities on multiple medications, probably sertraline and escitalopram will be a better option for them because we know they have good safety profile. For example, sertraline has a big study called SAD Heart that was in patient with coronary artery disease that they just had a bypass surgery or a PCI by left heart cath, and sertraline showed to be beneficial and in the same time showed to be safe with no drug-to-drug interaction. The other medicine that had a good data from the MACE trial is escitalopram, showed also safety in patients with cardiovascular disease. So really, I know these two medications do not have much drug-to-drug interaction. The other thing is other comorbidities. For example, if someone has binge eating, probably fluoxetine is the best option. If someone has comorbid anxiety, probably paroxetine is a good option here because it does block the 5-HT1A receptor, helping anxiety even with lower dosages. Comorbid OCD, probably fluvoxamine is a good option for these patients. And always remember, citalopram could cause QTC prolongation, so make sure you check an EKG before you start this medication. It's a little sedating from some antihistamine effect. Also, SNRIs could be started. It's better to go to the SNRI class after at least 2 SSRI failures, but sometimes it could be your first line treatment, especially if someone has either previous failures from the SSRI group or they have favorable response to one of the SNRI and one of their family members. So if someone tells you, oh, my mom did well on duloxetine or venlafaxine, it is a good option to start duloxetine or venlafaxine. These medications, the SNRIs, target serotonin and norepinephrine. And they may be a little beneficial in patients with chronic pain because duloxetine is approved for diabetic neuropathy, approved for fibromyalgia, and lots of chronic pain syndromes. So again, it's preferred to do a combined therapy, which is a medication, an SSRI, or SNRI plus psychotherapy. Now, and also we monitor 4 to 6 weeks. Every time we do any therapeutic approach, we wait for 4 to 6 weeks because most of these medication will need at least 4 to 6 weeks to work. And here, let me just put a small little information on the side. After you give an antidepressant, let's say you give an SSRI, within 24 hours, the serotonin level in the cerebrospinal fluid becomes normal. But still, the medicine takes 4 to 6 weeks to work. If you ever wonder why, because literally we increase serotonin, we stimulate the upregulated serotonin receptors. We can make patients worse, actually, the first couple of weeks. Then after that, we turn on the tyrosine kinase cascade, and then we turn on the brain-derived neurotrophic factor that will start doing some neurogenesis and synaptogenesis. And one study actually showed that actually it was done in mice. So mice randomized to receive fluoxetine versus placebo, and they looked at their brain cells, and they really found that after 28 days, 4 weeks on average, we had more neuronal activity in mice brain after they were treated with fluoxetine. So really, we have increase in brain-derived neurotrophic factor from antidepressant treatment that will take at least 4 weeks on average to cause some sort of neuromodulation. And it may take longer than that in some patients. For severe major depression disorder, again, we need to identify, do I have psychotic features or no psychotic features? If there is no psychotic features, antidepressant treatment plus psychotherapy. I cannot skip any of these two therapeutics here. If there is psychotic features or there is acute suicidality, antidepressants plus antipsychotics are recommended, and actually even electroconvulsive therapy. We should consider that very early, like even before adding the antipsychotic. So, or we can do it like in the same time. So we add the antidepressant plus the antipsychotic, monitor the patient for a couple of days, then start the electroconvulsive treatment. Again, ECT still the best treatment in psychiatry. That's proven, and it's very well tolerated. So this is something that we should always consider. Early consideration is better for severe major depression disorder with psychosis or with acute suicidality. And always remember that ECT over the years helped lots of patients, and lots of patients would, really not respond to anything but electroconvulsive treatment. So then, the next step, you reassess at 4 to 8 weeks. If you have adequate response, you continue treatment, and you maintain for 6 to 12 months if this is the first episode. If we have multiple episodes of depression, it is better to take these medications longer. And actually, some cases, the patient may need to take them lifelong. If we have partial response, we need to optimize the dose, add psychotherapy if it's not added, and we consider augmentation. And I will talk about augmentation strategies. If there's no response, switch classes. So if someone did not respond switch the antidepressant, So if someone did not respond to the first antidepressant, switch to another one. If they don't respond after 2 antidepressants from this class, switch to a different class. Now, augmentation. The easiest augmentation is to add another antidepressant from a different mechanism of action. So for example, your patient is on an SSRI or SNRI. You can always add bupropion or add mirtazapine to augment the effect of medication. However, this may take a little longer before it works. Adding atypical antipsychotics approved for major depression disorder as adjunct, like aripiprazole, brexpiprazole, quetiapine, extended release, or cariprazine. Adding low-dose lithium, adding thyroid hormone, especially liothyronine, is very, very common and very beneficial. Light therapy is another thing. Now, for treatment-resistant depression, we're going to talk about it. This is when we need to consider electroconvulsive treatment, repetitive TMS or deep TMS, and esketamine. Now, for maintenance or relapse prevention, we need to really have a good conversation with patients that they had multiple episodes of major depressive disorder. That means they need to be on medicine for a long time. And I would approach it from another way. So if someone has high blood pressure or hypertension, they need to be on antihypertensive probably forever. Well, I do not see any difference between hypertension and major depressive disorder. Major depressive disorder, if you remember, we said it's a genetic, epigenetic, inflammatory illness that has problem with neuromodulation, right? So it is in the genes. So really, I'm talking about treatment that will suppress the chronic inflammation that we have. So for maintenance, relapse prevention, we need to continue effective treatment. Ongoing psychotherapy is very important with very often checks. So sometimes the patient finishes their CBT course or treatment course, and they need just a reminder every once in a while. Every time we see the patient, we have to address sleep, exercise, substance use. We have to screen for that, even when they improve. And really, we need to tell them if we have more than 2 episodes or severe episodes or chronic depression, the patient needs to be on long-term maintenance. Could be lifelong, depends on the severity of illnesses. Now, the very important part of today's talk, treatment-resistant depression. So really, treatment-resistant depression represent one of the most challenging conditions in clinical psychiatry. Before labeling a patient as having treatment-resistant depression, we should really engage in a systematic and deliberate reassessment of diagnosis, contributing conditions, and treatment adequacy. And if we fail to do so, we're going to risk misclassification, inappropriate treatment, and prolonged suffering. So again, the first thing, I need to make sure I am treating the right illness. So treatment-resistant depression is defined as major depressive disorder that fails to achieve an adequate clinical response despite at least 2 trials of antidepressant medications that are from different pharmacological classes given at an adequate dose and for an adequate duration, usually more than 6 to 8 weeks, and with confirmed adherence. So really, I need to make sure that I tried at least 2 medicines from 2 different classes. I give them enough dose for at least 6 to 8 weeks, and I need to make sure that the patient took the medicine. When patients do not take the medicine don't work, right? So this definition is most commonly used in clinical practice and research, and it's consistent with how treatment-resistant depression is operationalized alongside DSM-5-TR-based diagnosis. So really, like, key clarification clinicians should apply. Again, adequate response, more than 50% reduction in depressive symptoms. Pseudo-resistance must be excluded first. So incorrect diagnosis, inadequate dose or duration, non-adherence, ongoing psychological stressors or medical contributors, like someone has untreated or undertreated hypothyroidism. It's not gonna work if you don't fix that first. And, there is actually a staging system for treatment-resistant depression. So we have the main thing, we have like 3 stages. So stage 1, failure of 1 adequate antidepressant trial. Stage 2, failure of 2 adequate trials from 2 different classes, which is the classical treatment-resistant depression. Stage 3, which is severe treatment-resistant depression, is failure of multiple trials, plus augmentation, psychotherapy, or neuromodulation. This is actually the highest level of treatment-resistant depression. So really, how to approach it? Step 1, confirm the correct diagnosis. Step 2, exclude psychiatric and medical mimics. Step 3, assess treatment adherence. Step 4, pharmacogenetic and neurobiological consideration. This is very important to think about. We'll talk about them. Step 5, chronicity and impaired neuroplasticity. So to talk about them here, the first one, we have to confirm the correct diagnosis. First and most critical step is to confirm the right diagnosis. I need to make sure that I'm treating unipolar depression. I do not have bipolar. I do not have substances. I do not have medical causes. I do not have personality disorder as the sole reason for the patient's symptoms. I have to exclude the other psychiatric and medical disorder as the sole reason for the patient's symptoms. No medical contributors like hypothyroidism. Hypogonadism is another biggie. Lots of patients are deficient in testosterone. Treatment of depression is not going to work unless I replenish their testosterone level. Other systemic or endocrine disorders should be looked at. Failure to identify and treat these decisions or conditions may falsify label a patient as treatment resistant, and they are not. After diagnostic clarification, medication adherence must be carefully evaluated. Non-adherence, whether due to side effect, misunderstanding, stigma, or psychosocial barriers, is one of the most frequent and overlooked cause of antidepressant failure. A treatment cannot be considered ineffective if it has not been taken consistently and as prescribed. Now we go to something very interesting, the pharmacogenetic and neurobiological consideration. So if I'm treating the right illness and I know the patient is taking the medicine, adherence is confirmed, so we should really shift our attention to biological factors that may limit antidepressant efficacy. So we talked about the first one and the second one, the serotonin transporter polymorphism. So if someone has SL or SS allele of the serotonin transporter gene, they may demonstrate reduced responsiveness to classical antidepressants. So they may not respond very well to SSRIs, SNRIs, or tricyclic antidepressants. In such cases, medications from different pharmacological classes, such as monoamine oxidase inhibitors, may be required. The other gene that we need to look at is folate metabolism and serotonin synthesis, so MTHFR gene mutations. This may have impaired folate metabolism, leading to reduced serotonin synthesis in the brain. The biological limitation can blunt response to standard antidepressant. So really, I don't have enough serotonin, so how can I boost it? The other factor here in the pharmacogenomics is the drug metabolism abnormalities. So variations in cytochrome enzyme P450 activity can significantly impact antidepressant plasma levels. So some patients are ultra rapid metabolizer that clears medicine very fast or too quickly. It's not enough to achieve therapeutic brain concentration. In these cases, higher dosages may be required, or alternative medication with different metabolic pathways may be necessary. So really, these considerations here underscore the clinical value of pharmacogenetic testing, particularly in patients who have failed multiple psychotropic trials. But again, it's a growing science and we do not have a full evidence there. For the chronicity of illness, in some patients, they've been depressed for so long and depressive symptoms have been present for such prolonged periods that the brain capacity for neuromodulation and synaptic plasticity becomes impaired. Here, chronic depression is associated with reduced responsiveness of neuronal circuit involved in mood regulation, limiting the effectiveness of conventional pharmacotherapy. So really, this is what we say. The brain goes into a vicious circle. They are depressed and the brain is unable to overcome the depression here. So really, if we want to put our brains together and have a treatment algorithm for treatment-resistant depression, the first core principle, or the core principle that we need to start with, is that all treatments for treatment-resistant depression should be combined with psychotherapy, with a particular emphasis on cognitive behavioral therapy because it has the best evidence base here. So psychotherapy enhances treatment response, improves adherence, and addresses maladaptive cognitive and behavioral pattern that pharmacological or somatic treatment alone cannot fully resolve. And of course, another core principle here that I would say this is more in the supplement kind of category still. In patient with MTHFR gene mutation, folic acid or methylfolate augmentation could be beneficial. So really, it wouldn't hurt. It's a water-soluble vitamin. And I think patients with treatment-resistant depression, whether I know they have the MTHFR gene mutation or not, using folic acid in the morning may be beneficial. So the first step, antidepressant combination and augmentation strategies. So in patients who have failed multiple trials of SSRIs, SNRIs, or tricyclic antidepressants, the next step is actually augmentation rather than simple switching. So for example, you have failed couple SSRIs, one SNRI, one tricyclic, and now you say, okay, I'm going to pick a base antidepressant and augment it. So go over the history. If the patient say like this medicine worked a little bit, you'll be like, okay, great. So for example, venlafaxine worked a little bit. So you start with venlafaxine and you add mirtazapine. And here, mirtazapine and venlafaxine is a great combination. Actually demonstrated efficacy in the STAR-D trial. And really, this is a very commonly used strategy in treatment-resistant depression. So why is that? Mirtazapine, which is a solo antidepressant, you can use it by itself, by the way, but this medicine works on the alpha-2 receptors. So pretty much alpha-2 presynaptic receptors as a blocker. So it's alpha-2 antagonist. Antagonizing alpha-2 receptors is going to increase norepinephrine release in the presynaptic neuron, and that will lead to norepinephrine stimulating alpha-1 receptors postsynaptic on the serotonin neurons, and this will lead to serotonin release. So pretty much this medicine increased the release of serotonin and norepinephrine without blocking the reuptake pump or the serotonin transporter. So if someone has serotonin transporter gene mutation or polymorphism, we bypass that. So if someone has SL or SS allele, they usually respond to mirtazapine because it's alpha-2 blocker as a mechanism of action and not serotonin or norepinephrine reuptake inhibitor. The second thing, remember we say that when serotonin is low in depressed brain, we have upregulation of receptors, right? So this medication is 5-HT2C antagonist, blocks these upregulated receptor off the bat. 5-HT2C antagonism has antidepressant effect, may increase appetite. Also, this medication is 5-HT2A antagonist, which would contribute to antidepressant effect. Also, it's 5-HT3 antagonist, just like ondansetron. So this one is an antiemetic, reduces gastrointestinal side effects associated with increased serotonin. The other added effect is antihistaminergic activity that improves sleep and treat insomnia. The other medicine that you can use for augmentation is bupropion. So bupropion increases dopamine and norepinephrine, does not directly act on serotonin, and this is very useful for patients with fatigue, anhedonia, or they have sexual side effect from serotonergic agents. Now, the second step is to use one of the FDA-approved and evidence-based pharmacological augmentation. So the one that is FDA-approved first is atypical antipsychotic as adjunct. So actually several of them are approved by the FDA as adjunct treatment for major depression disorder. So here we have aripiprazole, brexpiprazole, cariprazine, or even quetiapine extended release. And also we have the option of combination olanzapine and fluoxetine, which is approved by the FDA for treatment-resistant depression. Now, we have other treatments that are not approved by the FDA, but they are very well studied, like lamotrigine. This is widely used and studied off-label. It can use as adjunct in treatment-resistant depression. Buspirone, some evidence as an augmenting strategy. The use of stimulant, even though I would discourage that, but we have some limited but some supportive data, of course, off-label use. Light therapy. 10,000 lux, morning exposure within 30 to 60 minutes of awakening for 20 to 30 minutes a day may be helpful. Thyroid hormone augmentation. Not everyone is a candidate for that. And we need to make sure thyroid tolerates it, everybody tolerates it. And this one is, it's an established effective strategy, at least in the psychiatric literature. And here we're talking about T3, not much T4. So not levothyroxine, we're talking about liothyronine. And the way it works actually increase monoaminergic neurotransmission and modulate gene transcription related to mood regulation. The other augmenting medicine is lithium. This is one of the most evidence-based augmentation strategy in treatment-resistant depression. Really how it works, it enhances antidepressant response across multiple antidepressant classes, modulates second messenger system, enhance serotonergic neurotransmission, and does increase brain-derived neurotrophic factor expression and neuroplasticity. But of course, we have big problem with the renal function, thyroid function, and also interaction with other medications. So it's not the best option in this time of the medical practices. Step 3 is actually neuromodulation and novel treatment. So transcranial magnetic stimulation like repetitive TMS or deep TMS. They are well studied, safe, and effective modalities. So they can be used after failure of 2 antidepressants, in some circumstances after 1 failure, produce very good clinical results, and they act through neuromodulation, increase brain-derived neurotrophic factor, enhance neuroplasticity. Esketamine is another option, which is FDA approved for treatment-resistant depression, and this one is considered when pharmacological augmentation strategies fail. Really, this one promotes neuromodulation, also increase brain-derived neurotrophic factor, and enhance neuroplasticity. Step 4, if everything else failed, we're talking about electroconvulsive treatment or ECT. This remains the most effective treatment for severe or refractory depression and should be considered when all treatment have failed or patient has severe major depression disorder with psychotic features. Again, early consideration in psychotic depression is very important. In these cases, ECT may be used early and even as a first-line treatment, by the way. The last thing here is deep brain stimulation and vagus nerve stimulation, treatment-resistant depression. These are invasive neuromodulation strategies, but reserved for severe, chronic, and highly treatment-resistant depression. You failed everything. After you fail ECT, this is when you have a conversation with your patient family, that we need to go invasive. So vagus nerve stimulation, it's a surgical implantation of a pulse generator to the left cervical vagus nerve. Stimulation modulates afferent vagal pathways, projecting to key mood regulating regions, including locus coeruleus, dorsal raphe nucleus, limbic, and prefrontal circuits. So what happened? Physiological effect, it will enhance serotonin and norepinephrine transmission, modulate inflammatory pathways, gradual increase in brain-derived neurotrophic factor, and long-term neuroplastic changes. But the problem here, vagal nerve stimulation effects often accumulate slowly over months, which is unlike antidepressants. That will reflect circuit level remodeling rather than acute neurotransmitter effect. We should consider vagus nerve stimulator in patients with chronic major depressive disorder, failure, multiple antidepressant trials, failure or intolerance of ECT or TMS, long-standing illness with functional impairment, failure of esketamine, that's another one. And again, this is a long-term adjunctive therapy, not for rapid symptoms relief. We need to know that. So patient symptoms are not going to go away rapidly. It's going to take 6 to 12 months. And response rates increase over time. And chronic recurrent depression, this may work. But there's nothing without side effects, right? So hoarseness, voice changes, throat discomfort, cough, neck pain could happen, and these are usually stimulation dependent and adjustable, but they could be very frustrating. The other one is actually deep brain stimulation, which is a stereotactic implantation of electrodes into specific brain regions implicated in depression, with continuous electrical stimulation to normalize the dysfunctional neuronal circuits. So Brodmann area 25, which is the subcallosal cingulate, ventral capsule, ventral striatum, nucleus accumbens. These are common investigational targets. And really, deep brain stimulator will alter network connectivity, emotional regulation circuit, reward and motivational pathway. And this is actually the most precise form of neuromodulation currently available. When should we consider that? Extreme refractory treatment-resistant depression, failure of medications, augmentation, psychotherapy, TMS, esketamine, ECT, and we need to make sure that patients are treated in specialized research or tertiary referral center somehow. DBS remains largely investigational in depression, with ongoing refinement of targets and stimulation patterns. Again, some patients demonstrate dramatic and sustained improvement, and outcomes are heterogeneous. But again, it's very invasive. Optimal patient selection and stimulation targets still under study. High cost, surgical risk limits the widespread use. We all understand that. But when we have severe unresponsive depression, that may be an option.
If you found this video helpful, don't forget to like, subscribe, and hit the bell icon so you never miss future content.